The investigation and treatment of couples with recurrent first trimester and second trimester miscarriage. Green Top Guideline number 17, April 2011. Background and introduction. Miscarriage is defined as the spontaneous loss of pregnancy before the fetus reaches viability. The term therefore includes all pregnancy losses from the time of conception until 24 weeks of gestation. Recurrent miscarriage, defined as the loss of 3 or more consecutive pregnancies, affects 1% of couples trying to conceive. It has been estimated that 1 to 2% of second trimester pregnancies miscarry before 24 weeks of gestation. Risk factors for recurrent miscarriage. What are the causes of recurrent first trimester miscarriage and second trimester miscarriage? Epidemiological factors. Maternal age and number of previous miscarriages are two independent risk factors for a further miscarriage. Advancing maternal age is associated with a decline in both the number and quality of the remaining oocytes. A large prospective register linkage study reported the age-related risk of miscarriage in recognized pregnancies to be 12 to 19 years, 13%, 20 to 24 years, 11%, 25 to 29 years, 12%, 30 to 34 years, 15%, 35 to 39 years, 25%, 40 to 44 years, 51%, and greater than or equal to 45 years, 93%. Advanced paternal age has also been identified as a risk factor for miscarriage. The risk of miscarriage is highest among couples where the woman is greater than or equal to 35 years of age and the man is equal or greater than to 40 years of age. Previous reproductive history is an independent predictor of future pregnancy outcome. The risk of a further miscarriage increases after each successive pregnancy loss, reaching approximately 40% after 3 consecutive pregnancy losses, and the prognosis worsens with increasing maternal age. A previous live birth does not preclude a woman developing recurrent miscarriage. Maternal cigarette smoking and caffeine consumption have been associated with an increased risk of spontaneous miscarriage in a dose-dependent manner. However, current evidence is insufficient to confirm this association. Heavy alcohol consumption is toxic to the embryo and the fetus. Even moderate consumption of 5 or more units per week may increase the risk of sporadic miscarriage. Working with or using video display terminals does not increase the risk of miscarriage. The evidence on the effect of anesthetic gases for theater workers is conflicting. Antiphospholipid syndrome. Antiphospholipid syndrome is the most important treatable cause of recurrent miscarriage. Antiphospholipid syndrome refers to the association between antiphospholipid antibodies, lupus anticoagulant, anti-cardiolipin antibodies, and anti-B2 glycoprotein 1 antibodies, and adverse pregnancy outcome or vascular thrombosis. Adverse pregnancy outcomes include 3 or more consecutive miscarriages before 10 weeks of gestation, 1 or more morphologically normal fetal losses after the 10th week of gestation, 1 or more preterm births before the 34th week of gestation owing to placental disease. The mechanism by which antiphospholipid antibodies cause pregnancy morbidity include inhibition of trophoblastic function and differentiation, activation of complement pathways at the maternal-fetal interface, resulting in a local inflammatory response, and in later pregnancy, thrombosis of the uteroplacental vasculature. In vitro studies have shown that the effect of antiphospholipid antibodies on trophoblast function and complement activation is reversed by heparin. Antiphospholipid antibodies are present in 15% of women with recurrent miscarriage. By comparison, the prevalence of antiphospholipid antibodies in women with a low-risk obstetric history is less than 2%. In women with recurrent miscarriage associated with antiphospholipid antibodies, the live birth rate in pregnancies with no pharmacological intervention has been reported to be as low as 10%. Genetic factors. Parental chromosomal rearrangement. In approximately 2 to 5% of couples with recurrent miscarriage, one of the partners carries a balanced structural chromosomal anomaly, most commonly a balanced reciprocal or Robertsonian translocation. Although carriers of a balanced translocation are usually phenotypically normal, their pregnancies are at increased risk of miscarriage and may result in a live birth with multiple congenital malformation and/or mental disability secondary to an unbalanced chromosomal arrangement. The risk of miscarriage is influenced by the size and the genetic content of the rearranged chromosomal segments. In couples with recurrent miscarriage, chromosomal abnormalities of the embryo account for 30 to 57% of further miscarriages. The risk of miscarriage resulting from chromosomal abnormalities of the embryo increases with advancing maternal age. As the number of miscarriages increases, the risk of euploid pregnancy loss increases. Anatomical factors. Congenital uterine malformations. The exact contribution that congenital uterine anomalies make to recurrent miscarriage remains unclear since the prevalence and reproductive implications of uterine anomalies in the general population are unknown. The reported prevalence of uterine anomalies in recurrent miscarriage population ranges between 1.8% and 37.6%. The prevalence of uterine malformations appears to be higher in women with second trimester miscarriages compared with women who suffer first trimester miscarriages, but this may be related to the cervical weakness that is frequently associated with uterine malformation. The prevalence of uterine malformations appears to be higher in women with second trimester miscarriages compared with women who suffer first trimester miscarriages, but this may be related to the cervical weakness that is frequently associated with uterine malformation. It has been reported that women with arcuate uteri tend to miscarry more in the second trimester, while women with septate uteri are more likely to miscarry in the first trimester. A retrospective review of reproductive performance in women with untreated uterine anomalies has suggested that these women experience high rates of miscarriage and preterm delivery, with a term delivery rate of only 50%. Cervical weakness. Cervical weakness is a recognized cause of second trimester miscarriage, but the true incidence is unknown since the diagnosis is essentially a clinical one. There is currently no satisfactory objective test that can identify women with cervical weakness in the non-pregnant state. The diagnosis is usually based on a history of a second trimester miscarriage preceded by a spontaneous rupture of membranes or painless cervical dilatation. Endocrine factors. Systemic maternal endocrine disorders such as diabetes mellitus and thyroid disease have been associated with miscarriage. Women with diabetes who have high hemoglobin A1C levels in the first trimester are at risk of miscarriage and fetal malformation. However, well-controlled diabetes mellitus is not a risk factor for recurrent miscarriage, nor is treated thyroid dysfunction. The prevalence of diabetes mellitus and thyroid dysfunction in women who suffer recurrent miscarriage is similar to that reported in the general population. Antithyroid antibodies have been linked to recurrent miscarriage. The presence of thyroid antibodies in euthyroid women with a history of recurrent miscarriage does not affect future pregnancy outcome. Polycystic ovary syndrome, or PCOS, has been linked to an increased risk of miscarriage, but the exact mechanism remains unclear. Polycystic ovarian morphology, elevated serum luteinizing hormone levels, or elevated serum testosterone levels, although markers of polycystic ovary syndrome, do not predict an increased risk of future pregnancy loss among ovulatory women with a history of recurrent miscarriage who conceive spontaneously. The increased risk of miscarriage in women with polycystic ovary syndrome has been recently attributed to insulin resistance, hyperinsulinemia, and hyperandrogenemia. The prevalence of insulin resistance is increased in women with recurrent miscarriage compared with much fertile controls. An elevated free androgen index appears to be a prognostic factor for a subsequent miscarriage in women with recurrent miscarriage. Immune factors. There is no clear evidence to support the hypothesis of human leukocyte antigen incompatibility between couples, the absence of maternal leukocytotoxic antibodies, or the absence of maternal blocking antibodies. Hence, they should not be offered routinely in the investigation of couples with recurrent miscarriage. Infective agents. Any severe infection that leads to bacteremia or viremia can cause a sporadic miscarriage. The role of infection in recurrent miscarriage is unclear. For an infective agent to be implicated in the etiology of repeated pregnancy loss, it must be capable of persisting in the genital tract and avoiding detection, or must cause insufficient symptoms to disturb the woman. Toxoplasmosis, rubella, cytomegalovirus, herpes, and listeria infections do not fulfill this criteria, and routine torch screening should be abandoned. The presence of bacterial vaginosis in the first trimester of pregnancy has been reported as a risk factor for second trimester miscarriage and preterm delivery, but the evidence for an association with first trimester miscarriage is inconsistent. Treatment of bacterial vaginosis early in the second trimester with oral clindamycin significantly reduces the incidence of second trimester miscarriage and preterm birth in the general population. There are no published data to assess the role of antibiotic therapy in women with a previous second trimester miscarriage. Inherited thrombophilic defects. Both inherited and acquired thrombophilias, including activated protein C resistance, most commonly due to factor V Leiden mutation, deficiencies of protein CS, and antithrombin 3, hyperhomocystinemia, and prothrombin gene mutation are established causes of systemic thrombosis. In addition, inherited thrombophilias have been implicated as a possible cause in recurrent miscarriage in late pregnancy complications, with the presumed mechanism being thrombosis of the utero-placental circulation. The magnitude of the association between inherited thrombophilias and fetal loss varies according to type of fetal loss and type of thrombophilia. The association between thrombophilia and late pregnancy loss has been consistently stronger than for early pregnancy loss. Carriers of factor V Leiden or prothrombin gene mutation have double the risk of experiencing recurrent miscarriage compared with women without these thrombophilic mutations. What are the recommended investigations of couples with recurrent first trimester miscarriage and second trimester miscarriage? Women with recurrent first trimester and second trimester miscarriage should be looked after by a health professional with the necessary skills and expertise. Where available, this might be within a recurrent miscarriage clinic. Ideally, the couple should be seen together at a dedicated recurrent miscarriage clinic and given accurate information to facilitate decision making about future pregnancies. Clearly written patient leaflets are recommended to provide written information that the couple can take home. Antiphospholipid antibodies. All women with recurrent first trimester miscarriage and all women with one or more second trimester miscarriage should be screened before pregnancy for antiphospholipid antibodies. To diagnose antiphospholipid syndrome, it is mandatory that the woman has two positive tests at least 12 weeks apart for either lupus anticoagulant or anticardiolipin antibodies of immunoglobulin G and or immunoglobulin M class present in a medium or high titer over 40 grams per liters or milliliters per liters or above the 99th percentile. In the detection of lupus anticoagulant, the dilute Russell's Viper venom time test, together with a platelet neutralization procedure, is more sensitive and specific than either the activated partial thromboplastin time test or the kaolin clotting time test. Anticardiolipin antibodies are detected using a standardized enzyme-linked immunosorbent assay. The detection of antiphospholipid antibodies is subject to considerable interlaboratory variation. This is a result of temporal fluctuation of antiphospholipid antibody titers in individual women, transient positivity secondary to infections, suboptimal sample collection, and preparation and lack of standardization of laboratory tests for their detection. Karyotyping. Cytogenetic analysis should be performed on products of conception on the third and subsequent consecutive miscarriage or miscarriages. Parental peripheral blood karyotyping of both partners should be performed in couples with recurrent miscarriage where testing of products of conception reports an unbalanced structural chromosomal abnormality. Knowledge of the karyotype of the products of conception allows an informed prognosis for a future pregnancy outcome to be given. While a sporadic fetal chromosome abnormality is the most common cause of any single miscarriage, the risk of miscarriage as a result of fetal aneuploidy decreases with an increasing number of pregnancy losses. If the karyotype of the miscarried pregnancy is abnormal, there is a better prognosis for the next pregnancy. Routine karyotyping of couples with recurrent miscarriage cannot be justified. Anatomical factors. All women with recurrent first trimester miscarriage and all women with one or more second trimester miscarriages should have a pelvic ultrasound to assess uterine anatomy. Suspected uterine anomalies may require further investigations to confirm the diagnosis using hysteroscopy, laparoscopy, or three-dimensional pelvic ultrasound. A review of studies comparing the diagnostic accuracy of various imaging modalities has reported that two-dimensional ultrasound scanning and/or hysterosalpingography can be used as an initial screening test. Combine hysteroscopy and laparoscopy, and possibly three-dimensional ultrasound scanning should be used for a definitive diagnosis. The value of magnetic resonance imaging scanning remains undetermined. Thrombophilias. Women with second trimester miscarriage should be screened for inherited thrombophilias, including factor V latent, factor II prothrombin gene mutation, and protein S. A meta-analysis of retrospective studies has reported a strong association between second trimester miscarriage and inherited thrombophilias, factor V latent, factor II prothrombin gene mutation, and protein S deficiency. Treatment options for recurrent miscarriage. What are the treatment options for recurrent first trimester and second trimester miscarriage? Women with recurrent miscarriage should be offered referral to a specialist clinic. Antiphospholipid syndrome. Pregnant women with antiphospholipid syndrome should be considered for treatment with low-dose aspirin plus heparin to prevent further miscarriage. The only treatment or treatment combination that leads to a significant increase in the live birth rate among women with antiphospholipid syndrome is aspirin plus unfractionated heparin. This treatment combination significantly reduces the miscarriage rate by 54%. Two small prospective studies reported no difference in efficacy and safety between unfractionated heparin and low molecular weight heparin when combined with aspirin in the treatment of women with recurrent miscarriage associated with antiphospholipid antibodies. There are no adverse fetal outcomes reported in the meta-analysis of randomized controlled trials of low-dose aspirin for the prevention of preeclampsia in pregnancy. Heparin does not cross the placenta, and hence there is no potential to cause fetal hemorrhage or teratogenicity. Heparin can, however, be associated with maternal complications, including bleeding, hypersensitivity reactions, heparin-induced thrombocytopenia, and when used long-term, osteopenia and vertebral fractures. The loss of bone mineral density at the lumbar spine associated with low-dose long-term heparin therapy is similar to that which occurs physiologically during normal pregnancy. Low molecular weight heparin is as safe as unfractionated heparin and has potential advantages during pregnancy since it causes less heparin-induced thrombocytopenia, can be administered once daily, and is associated with a lower risk of heparin-induced osteoporosis. Pregnancies associated with antiphospholipid antibodies treated with aspirin and heparin remain at high risk of complications during all 3 trimesters. Although aspirin plus heparin treatment substantially improves the live birth rate of women with recurrent miscarriage associated with antiphospholipid antibodies, these pregnancies remain at high risk of complications during all 3 trimesters, including repeated miscarriage, preeclampsia, fetal growth restriction, and preterm birth. This necessitates careful antenatal surveillance. Neither corticosteroids nor intravenous immunoglobulin therapy improve the live birth rate of women with recurrent miscarriage associated with antiphospholipid antibodies compared with other treatment modalities. Their use may provoke significant maternal and fetal morbidity. Genetic factors. The finding of an abnormal parental karyotype should prompt referral to a clinical geneticist. Genetic counseling offers the couple a prognosis for the risk of future pregnancies with an unbalanced chromosome complement and the opportunity for familial chromosome studies. Reproductive options in couples with chromosomal rearrangements include proceeding to a further natural pregnancy with or without a prenatal diagnosis test, gamete donation, and adoption. Pre-implantation genetic diagnosis has been proposed as a treatment option for translocation carriers. Since pre-implantation genetic diagnosis necessitates that the couple undergo in vitro fertilization to produce embryos, couples with proven fertility need to be aware of the financial costs as well as implantation and live birth rates per cycle following in vitro fertilization or pre-implantation genetic diagnosis. Furthermore, they should be informed that they have a higher 50 to 70% chance of a healthy live birth in future untreated pregnancies following natural conception than is currently achieved after pre-implantation genetic diagnosis or in vitro fertilization, approximately 30%. Pre-implantation genetic screening with in vitro fertilization treatment in women with unexplained recurrent miscarriage does not improve live birth rates. Anatomical factors. Congenital uterine malformations. There is insufficient evidence to assess the effect of uterine septum resection in women with recurrent miscarriage and uterine septum to prevent further miscarriage. Cervical weakness and cervical cerclage. Cervical cerclage is associated with potential hazards related to the surgery and the risk of stimulating uterine contractions, and hence should be considered only in women who are likely to benefit. Women with a history of second trimester miscarriage and suspected cervical weakness who have not undergone a history-indicated cerclage may be offered serial cervical sonographic surveillance. In women with a singleton pregnancy and a history of 1 second trimester miscarriage attributable to cervical factors, an ultrasound-indicated cerclage should be offered if a cervical length of 25 millimeters or less is detected by transvaginal scan before 24 weeks of gestation. A short cervical length on transvaginal ultrasound during pregnancy may be useful in predicting preterm birth in some cases of suspected cervical weakness. A meta-analysis of individual patient-level data from 4 randomized controlled trials reported that in a subgroup analysis of women with a singleton pregnancies, a short cervix, less than 25 millimeters, and previous second trimester miscarriage, cerclage may reduce the incidence of preterm birth before 35 weeks of gestation. Transabdominal cerclage has been advocated as a treatment for second trimester miscarriage and the prevention of early preterm labor in selected women with a previous failed transvaginal cerclage and/or a very short and scarred cervix. Endocrine factors. There is insufficient evidence to evaluate the effect of progesterone supplementation in pregnancy to prevent a miscarriage in women with recurrent miscarriage. Progesterone is necessary for successful implantation and the maintenance of pregnancy. This benefit of progesterone could be explained by its immunomodulatory actions in inducing a pregnancy protective shift from pro-inflammatory Th1 cytokine responses to a more favorable anti-inflammatory Th2 cytokine response. A large multi-center study, or PROMISE, that can be found on www.medscnet.net/promise is currently underway to assess the benefit of progesterone supplementation in women with unexplained recurrent miscarriage. There is insufficient evidence to evaluate the effect of human chorionic gonadotropin supplementation in pregnancy to prevent a miscarriage in women with recurrent miscarriage. Suppression of high luteinizing hormone levels among ovulatory women with recurrent miscarriage and polycystic ovaries does not improve the live birth rate. Luteinizing hormone hypersecretion, a frequent feature of polycystic ovary syndrome, has been reported as a risk factor for early pregnancy loss. There is insufficient evidence to evaluate the effect of metformin supplementation in pregnancy to prevent a miscarriage in women with recurrent miscarriage. Immunotherapy. Paternal cell immunization, third-party donor leukocytes, trophoblast membranes, and intravenous immunoglobulin in women with previous unexplained recurrent miscarriage does not improve the live birth rate. Moreover, immunotherapy is expensive and has potentially serious adverse effects, including transfusion reaction, anaphylactic shock, and hepatitis. There are no published data on the use of anti-tumor necrosis factor agents to improve pregnancy outcome in women with recurrent miscarriage. Furthermore, anti-tumor necrosis factor agents could potentially cause serious morbidity, including lymphoma, granulomatous disease such as tuberculosis, demyelinating disease, congestive heart failure, and syndromes similar to systemic lupus erythematosus. Inherited thrombophilias. There is insufficient evidence to evaluate the effect of heparin in pregnancy to prevent a miscarriage in women with recurrent first trimester miscarriage associated with inherited thrombophilia. Heparin therapy during pregnancy may improve the live birth rate of women with second trimester miscarriage associated with inherited thrombophilias. Unexplained recurrent miscarriage. Women with unexplained recurrent miscarriage have an excellent prognosis for future pregnancy outcome without pharmacological intervention if offered supportive care alone in the setting of a dedicated early pregnancy assessment unit. A significant proportion of cases of recurrent miscarriage remain unexplained despite detailed investigation. These women can be reassured that the prognosis for a successful future pregnancy with supportive care alone is in the region of 75%. However, the prognosis worsens with increasing maternal age and the number of previous miscarriages. Attendance at a dedicated early pregnancy clinic has a beneficial effect, although the mechanism is unclear. The use of empirical treatment in women with unexplained recurrent miscarriage is unnecessary and should be resisted.